So this clinical correlation will focus on ventricular arrhythmias. Case number 8. Mr. Popov is a 57-year-old male with a past medical history of childhood epilepsy, and he's recently seen in the clinic for an unusual ECG. He had recently gone to his employer's health fair and had several tests done, including blood work, blood pressure screening, and an ECG, which he was told is abnormal. He was told to follow up with his PCP for further guidance. He states that he's asymptomatic and has no complaints. Vital signs were temperature 98, pulse 60, respiratory 18, blood pressure 130/70. Physical exam was essentially normal. A 12-lead ECG shows the following. This ECG shows which of the following? A. Brugada syndrome. B. Long QT syndrome. C. Wolff-Parkinson-White syndrome. D. Early repolarization syndrome. Or E. Prinzmetal syndrome. And the answer is long QT syndrome. So if we go back, look at the Q to T interval here. We always want to approach ECGs looking at rate, rhythm, axis, etc. But we also want to focus on intervals, like the PR interval, the QRS duration, and the Q to T duration. And we can see here that the Q to T interval is pretty long. It's about at least 2 large boxes and probably over that. So we're getting into the 400 to 500 milliseconds range, which is pretty long. Another way to see this is that if the Q to T interval is half of the R to R interval, then that's a pretty long QT interval and could be pathogenic. So upon further questioning, the patient says he has a sister who was a competitive swimmer who almost died in practice in college, but was revived with CPR. He also had an uncle with sudden unexpected death at the age of 40 years old. Based on the patient's ECG and his family history, you suspect that he has which of the following? Long QT syndrome 1, long QT syndrome 2, long QT syndrome 3, or Anderson-Tawil syndrome, which is long QT syndrome 7. So the answer here is long QT syndrome 1. So one of the classic histories of somebody with long QT syndrome 1 is that they will actually have sudden ventricular arrhythmias or even sudden cardiac death with exercise, and swimming is the classic exercise that can induce fatal arrhythmias if you have long QT syndrome 1. The next question, long QT syndrome 1 is caused by a mutation in which gene? Is it A, SCN5A, B, KCNH2, C, KCNJ2, D, KCNQ1, or E, ANK2? And the answer is KCNQ1. So long QT syndrome is, in the genetic inherited version, is caused by mutations in potassium channels, at least in long QT1 and long QT2. And KCNQ1 is the genetic mutation that is most commonly associated with long QT1. Long QT3 is actually a sodium channel problem, and SCN5A is the correct answer if they ask about long QT3 on a test. And most of the time you'll see this on the pediatric shelf exam or potentially on the step 1 where they're asking about genetic inherited arrhythmias. Based on the patient's presentation, the next best step in his management includes A, an implantable cardioverter defibrillator, B, calcium channel blockers, C, left cardiac sympathetic denervation, D, avoidance of QT shortening drugs, or E, beta blockers. And the answer is beta blockers. So the guidelines state that in patients with long QT syndrome and a resting corrected QT interval greater than 470 milliseconds, a beta blocker is recommended. And it's even reasonable in a long QT that happens to be less than 470 milliseconds. In high-risk patients with symptomatic long QT syndrome, in whom a beta blocker is ineffective or not tolerated, intensification of therapy with additional medications, left cardiac sympathetic denervation, and/or an ICD is recommended. Also, in patients with long QT syndrome, QT prolonging medications are potentially harmful. So several months have gone by since Mr. Popov has been on beta blockers and has had a familial genetic screening. He has been stable and has kept a healthy, active lifestyle with light to moderate exercise. Recently, he developed a fever and a cough thought to be due to a community-acquired pneumonia. A chest x-ray confirmed bronchiectasis and ground glass opacities in the right lower lobe, and he was given oral azithromycin. 2 days later, the patient is emergently transferred by ambulance to the emergency center for cardiac arrest and CPR in progress. The ECG strip shows the following. So keeping this strip in mind, the ECG diagnosis in this patient is ventricular tachycardia A. Is it B, supraventricular tachycardia? C, torsades de pointe? D, accelerated junctional rhythm? Or E, ventricular pre-excitation? And the answer is torsades de pointe, C. So you can see, if we go back, that the patient has alternating low voltage and high voltage portions of the ventricular tachycardia. So this is a classic torsades de pointe. And you can kind of, if you hallucinate, you can kind of see that this looks like party streamers, where you have these larger and then smaller portions of the ventricular tachycardia. So this is torsades de pointe. So the next appropriate intervention for this patient is A, intubation, B, direct current cardioversion, C, chest compressions, D, epinephrine, or E, atropine. And the answer is B, direct current cardioversion. Remember, this patient is already receiving CPR in progress. And while the patient is receiving CPR, when you have a shockable rhythm, such as torsades de pointe, which is a type of ventricular tachycardia, then in addition to your ACLS algorithm, or as really a significant part of that, is direct current cardioversion. Okay, now let's move on to case 9. Mr. Jain is a 68-year-old male with a past medical history of hypertension, hyperlipidemia, and a 25-pack-year smoker who quit 2 years ago. He was in his usual state of health until last night, when he developed acute substernal chest pain with radiation to the neck and left arm. The pain was heavy, it was a binding type of pain, and was associated with shortness of breath, which was 8 of 10 in chest pain severity. He sought evaluation in the emergency department, where his vital signs are temperature 99, respiratory 24, pulse is 110, and blood pressure 80/54. He is acutely diaphoretic and appears pale and listless. He has no bruit, his neck is supple, jugular venous pressure is 7 centimeters. Auscultation of the heart shows regular tachycardia, normal S1, S2. There is an audible S3, and otherwise no rubs, clicks, and murmurs. Abdomen is soft, and the extremities have 1+ pulses bilaterally. Labs are drawn and ECG is performed, in which shows the following. So the ECG in this patient shows A, ST segment elevation myocardial infarction. B, non-ST elevation myocardial infarction. C, unstable angina. D, Prinzmetal's angina. Or E, pulmonary embolism with right ventricular strain pattern. And we'll go back to the ECG. Okay, so the answer is A, ST segment elevation myocardial infarction. You can clearly see the tombstone appearing elevated ST segments in leads V1, V2, V3. The patient's ECG demonstrates an acute STEMI myocardial infarction. The decision is made to perform percutaneous intervention via a heart catheterization. The cardiac catheter laboratory pager is activated and immediate preparations are made to transport the patient from the ED to the cath lab. While you are preparing the patient, he suddenly loses consciousness and becomes unresponsive. You are unable to palpate a pulse. Your next step in this scenario is A, give IV epinephrine. B, begin chest compressions. C, secure the patient's airway. D, deliver a shock or defibrillate. Or E, establish intravenous or intraosseous access. And the answer is B, begin chest compressions. So if we look at the guidelines, one of the first things that you do when somebody loses a pulse is you start CPR. You give oxygen, you can attach a monitor, but you're giving active chest compressions from the very moment that you lose a pulse. And so if we just highlight this section of the ACLS guidelines, you can see that starting CPR and beginning chest compressions is one of your first things to do. And if you want to look at the full ACLS guidelines, I gave the reference below, and there's a lot of different algorithms that you'll be required to know, especially in your last few years of medical school. During CPR and following the ACLS algorithm, intravenous access is established, defibrillator pads are placed, and ECG strips are obtained, and then you see the following 12-lead ECG. So your next step in the management of the patient is to deliver a shock or defibrillate. So if we just follow the algorithm down here, if the rhythm is shockable, so for example, in this situation we had ventricular tachycardia, then you go to the left of the algorithm and you can see that either ventricular fibrillation or polymorphic ventricular tachycardia is present, and so you can give a shock. And then immediately after the shock, you continue chest compressions for another 2 minutes. So the answer is not that you give a shock and then you see what happened. The answer is you give a shock, you give chest compressions, and then reassess after 2 minutes. And this is exactly where we're at in the algorithm. After the shock is given, 2 full minutes of CPR are then given per ACLS guidelines, and then the patient remains pulseless, and the ECG shows the following. Your next best step is to A, continue CPR, B, give epinephrine IV, C, consider an advanced airway, or D, all of the above. And the answer is D, all of the above. So continue compressions, give epinephrine as per the algorithm of ACLS, and consider an advanced airway. Due to your diligence as the code team, the patient restores a normal rhythm, and transport to the cath lab and catheterization shows a complete occlusion of the left anterior descending artery. Prompt angioplasty and stent placement restore flow to Mr. Jane's heart, and he has an otherwise uneventful recovery. Echocardiogram 2 weeks post-MI shows an LV ejection fraction of 45 to 50% and mild anterior wall motion abnormalities. He and his family are grateful for your life-saving interventions.